But why don't we turn now to Dr. Sue Chandra, who's one of our outstanding medical oncologists that helps us with our complex cutaneous malignancies.
Thanks, Jeff. Hi, everybody. Thanks for joining us this evening. There was a slight change to the agenda schedule. So today I'll be talking about systemic or whole body therapies that we have available to us for cutaneous squamous cell carcinoma, which I might call CSCC, and basal cell carcinoma, which I might call BCC. Next slide, please. So I'll be really focusing on cutaneous squamous cell as well as basal cell carcinoma in my portion of the talk. And then Dr. Jeff Sossman later is going to focus a little bit on Merkel cell carcinoma. Next slide, please. So when does medical oncology get involved? Usually, although it might be different for different cancers, in the non-melanoma skin cancer world, we usually get involved with more advanced stage scenarios. So when a person may have a BCC or a CSCC that is not amenable to further surgery and or radiation, at that time, systemic or whole body cancer therapy may be indicated. Next slide, please. So we have a number of therapies that are already FDA approved in these two cancers. For CSCC, or cutaneous squamous cell carcinoma, we have the anti-PD-1 antibodies that I'll get into a little bit more detail, namely Cemiplimab and Pembrolizumab. We also have targeted therapies, although it's an intravenous drug, cetuximab and our traditional chemotherapy. For BCC, or basal cell carcinoma, we have pills known as Hedgehog inhibitors that I'll explain in just a moment, namely sonitigib and vismodegib. And we also have anti-PD-1 antibody, specifically Cemiplimab. So these are the ones that are FDA approved for these two types of cancers. Next slide. So let's talk about what these hard to pronounce drugs, these anti-PD-1 antibodies, how they work. So examples of this that are approved in non-melanoma skin cancers are Cemiplimab and Pembrolizumab. So the way these work is here depicted in blue are the T cells. Now this T cell has been trained to recognize a piece of the non-melanoma skin cancer. That piece known as a neoantigen, here depicted, I believe, in this kind of orangey little part of the cartoon. That neoantigen is then recognized So the T cell recognizes that neoantigen and then basically goes into the tumor microenvironment to find similar cancer cells to kill it. Now, what happens traditionally is that T cell automatically becomes shut down by the natural human immune system, which then makes it a dysfunctional T cell, which is unable to then kill cancer. And what these PD-1 antibodies do is they basically activate that T cell so they can remain active and continue to kill the cancer cell. Now, we don't get something for nothing. So when we do that, it can cause a whole host of side effects that we can certainly talk about more if we have some time. Next slide, please. So next, I'll be talking about Hedgehog inhibitors. These are specifically only approved in basal cell carcinoma. The previous slide that was approved, those categories of drugs are approved in basal cell carcinoma, cutaneous squamous cell, and Merkel cell, but sonic hedgehog inhibitors are only approved in basal cell carcinomas. And the way this works is in a basal cell itself, this signaling pathway with the sonic hedgehog protein, the patch protein, the smoothened protein. In general, this signaling pathway can be active, leading to basal cell growth. And so the way these hedgehog inhibitors work is they basically block the protein, the sonic hedgehog protein, which then creates a downstream effect of blocking the signaling inside the cell. thereby causing basal cell death. So that's how these Hedgehog inhibitors work. Next slide. So in cutaneous squamous cell carcinoma, next slide, there's some risk factors for recurrence. And these are what we think about in our team, as well as in medical oncology specifically. So size, location, is it a primary? Is it a brand new spot, or is this like a recurrent spot? Has this spot undergone prior radiation? Are there pathologic features that Dr. Chen had spoken about that make it a little bit more higher risk? And then furthermore, is the patient immunocompromised? Next slide, please. So if a person has unresectable metastatic cutaneous squamous cell carcinoma, in the past, we only had drugs like chemotherapy or cetuximab to offer, but now we actually have these anti-PD-1 drugs that I'd previously alluded to that have really revolutionized how we treat these cancers. Now, when we talk about these drugs, I just wanted to give you a brief idea of how we think about the data. So this box on the top is called a waterfall plot. And each of these bars represents a particular person's tumor response. And all the downward deflections reflect tumor shrinkage. So the more downward deflections there are, the more this drug seems to be effective in causing tumor shrinkage. This bottom part of the slide on the bottom left shows derivative response. So in general, what this is showing is these therapies not only cause tumor regression in about 50% of patients, that's what the ORR means, objective response rate, but they're also long-standing. They're durable, which is what we want to see in our patients. And on the right, you see some pictorial, some pictures depicting these profound responses. Next slide, please. This is again showing what I just talked about. In addition, it's showing that after Cemiplimab, this particular person on the right not only had tumor on his anterior or front part of his neck and kind of chest, he also had tumor in his lungs. Next slide, please. And basically, one more. Basically, the Cemiplimab, the anti-PD-1 drug, caused a complete response visibly and about a 90% response in the lungs. So these can work profoundly well. Again, in this slide, you're seeing some not only pictures depicting actual posterior auricular or behind the ear masses, but you're also seeing the corresponding radiographic imaging on CT that's showing shrinkage of that mass as we visibly see disappearance of the mass. Next slide, please. So another paradigm, which is not FDA approved, but it's changing how we're starting to think of how to treat these cancers, is the neoadjuvant setting. So what that means is before someone goes to surgery with, for example, Dr. Alam or Dr. Stepan or Dr. Wayne, we can potentially give them these therapies before surgery to try to shrink the tumor. So we give a limited number of doses, and then at the time of surgery, hopefully the point is that it will improve their surgical outcomes. So because this is not FDA approved, we do this on a clinical trial, and we actually have clinical trials looking at this here at Northwestern, but this is really shown to be an effective way of shrinking tumor prior to taking someone to surgery. Next slide, please. Next, we'll talk about basal cell. Next slide, please. So the risk factors for basal cell are very similar to the ones I just mentioned for cutaneous squamous cell carcinoma. Next slide, please. So again, here, remember, in basal cell carcinoma, not only immunotherapy is approved, but these Hedgehog inhibitors, which are pills, are also approved therapies. And here, if you recall what I talked about, the waterfall plot, you see that most of the patients had shrinkage of tumor depicted by these downward deflections in this waterfall plot. Again, each bar is a particular person's response. So whether we try sunitinib in a person or vismodegib, the response rates can be quite significant, and they can last somewhere between maybe a year to 2 years. Next slide, please. Now, in the event that those therapies don't work, or if a person can't tolerate those therapies, then we go to anti-PD-1, specifically Cemiplimab, which is also shown to have a benefit in advanced basal cell carcinoma. But usually we only use this after someone has already tried a Hedgehog inhibitor. That's how it's FDA approved to be used. Next slide, please. So these are some profoundly responsive patients with Cemiplimab really shrinking and in these instances actually causing disappearance of their basal cell carcinoma. Next slide, please. So things to consider is we absolutely have more effective systemic or whole body therapy options in these cancers. One thing that's very important, as you guys have already probably gathered from our panel, is that it needs a very multidisciplinary team discussion, because the thought is, does medical oncology need to step in sooner, perhaps in a neoadjuvant setting, or should the person go to surgery right away? When does radiation play a role? Pathology is a huge issue. So tissue is the issue. We always say in medical oncology, we absolutely want people like Dr. Chen commenting on the exact pathologic features so we can figure out how risky a person's tumor might be. And then, of course, we have to help manage toxicities in a safe manner. We have to look at people in which these drugs aren't working. What do we offer them? And then we also have to think of special populations in which a person might be immunocompromised, such as people who have a solid organ transplant or other immunocompromised states. And then these traditional therapies may have to be considered a lot more thoughtfully. Thanks for your attention.